Today, we'll be discussing about placenta previa. Pre means before and via means way. That is, the placenta comes before the way of the fetus, which is usually through the internal os of the cervix. So, placenta previa is implantation of placenta partially or completely in the lower uterine segment. It is one of the common cause of antepartum hemorrhage. Usually, it causes about 30% of antepartum hemorrhage. The prevalence of placenta previa is around 4 per 1,000 pregnancies. Highest incidence is seen in Asian countries, and it is lower in European countries and the North American countries. The risk factors for placenta previa. The cause of placenta previa is not known, but it is associated with some risk factors, and the risk factors include the following: multiparity, advanced maternal age, usually age greater than 35 years, multiple gestation, previous history of placenta previa, previous cesarean section, uterine structural abnormalities such as biconduit uterus, smoking, and also diabetes mellitus have all been associated with high incidence of placenta previa. The classification of placenta previa includes type 1 to type 4. Type 1 is when the placenta is attached into the lower segment of the uterus, but it does not reach the edge of the internal os. While in type 2, the placenta just reaches the edge of the internal os, but it does not cover the opening of the internal os. This can be divided into type 2A and type 2B. Type 2A is the anterior and type 2B is the posterior type. Type 3, placenta covers the internal os when it is closed, but does not cover it completely when it is dilated. While in type 4, the placenta covers the internal os both when it is closed and when it is dilated.
Clinical features of placenta previa: painless vaginal bleeding. Fetal lie is often abnormal, obviously because you expect that the placenta occupies the lower uterine segment. So in attempt to compensate for this, the fetus lie abnormally. Fetal biophysical profile is usually normal because the bleeding is usually maternal. Investigations: packed cell volume, full blood count, hemoglobin electrophoresis, urine microscopy culture and sensitivity, abdominal and vaginal ultrasound scan, magnetic resonance imaging, examination under anesthesia. Management: if the bleeding is slight and the pregnancy is not term, expectant management is done. This is also called McAfee regimen. McAfee regimen is an expectant management done to support the woman to carry the pregnancy to term, or to as close as possible to term. This involves admitting the patient and ensuring bed rest, blood transfusion to correct low packed cell volume, grouping and cross-match of 4 units of blood. Patient keeps perineal pad, which should be checked twice daily to monitor bleeding. Fetal well-being monitoring, which includes the fetal biophysical profile and non-stress test. Maternal vital signs monitoring. Steroids such as dexamethasone, betamethasone can be used for lung maturation. If the gestational age is less than 34 weeks, at least 2 liters of intravenous fluid, wide bore cannula, fluid and blood given sets alongside oxygen should be available by patient's bedside in case of emergency. Facilities for cesarean section, blood transfusion, and neonatal care should be available. Lastly, give prophylaxis for rhesus isoimmunization where indicated. When to terminate McAfee regimen? McAfee regimen is terminated at gestational age greater than 38 weeks in situations of prelabor rupture of membranes, when the fetus is in distress, in situations of severe maternal bleeding, when the patient is in labor, in cases of congenital anomaly incompatible with life, for example anencephaly, trisomy 13 and trisomy 18, in cases of intrauterine fetal death. At term, types 1 and 2 can be supported to deliver the baby via the birth canal. For types 3, 4, and cases with severe bleeding, cesarean section should be done. Complications. Complications could be maternal or fetal. Maternal complications include hypovolemic shock, sepsis, disseminated intravascular coagulopathy, maternal vert, Fetal complications include intrauterine growth restriction, preterm delivery, respiratory distress syndrome, congenital anomaly, fetal death.